Hello, I hope everyone's doing well. Everyone seems to be doing well on homeworks and the quiz. So I'm not going to go over any of that in for this lecture, but this lecture will cover the information that will be on in homework number 5. So we're just going to dig in right now. And sure. Get rid of this real quick. So today we're going over major concepts within the U.S. health systems, and specifically we'll be covering health insurance, which we've covered a little bit of previously. There's a little bit of overlap with this lecture and some of the previous lectures. We're going to dive into adverse selection and moral hazard, which I have shown you a brief video on also. But we'll really clarify those today, and then a supplier induced demand. So this is a very health economics heavy lecture today. Okay, concept number 1, health insurance. So I'm going to stop sharing this, and I'm going to show you a really good video. Where did I put it? Maybe I'm going to show that to you. Think it is. Hold on. Let me go in here and make sure it's up. There it is. Sorry about the wait on this. So let me put it here. Okay. But I only have the ability to cut some of this dead air. Oh. Okay, so here you go.
You're deciding which insurance plan to purchase and want to know how much is it going to cost. Well, it's not so simple. Sometimes you pay money toward your health care. Sometimes the insurance company pays money. But when? To figure it all out, there are 3 main ideas you need to know: premiums, deductibles, and out-of-pocket maximum. It may sound complicated, but stay with us. It's not as hard to understand as you think. First, premiums. Think of your insurance as a monthly membership. Every month you pay the same amount in order to be a member. That amount is your premium. With your premium, say $200 a month, you get some preventive care for free. This includes care like vaccines and screening for diabetes, cholesterol, and breast cancer. This care is covered by your premium. But what if you need more than just preventive care? If you need a health service beyond preventive care, illnesses, a broken leg, emergency room visits, you usually need to pay extra. How much? Well, that changes over time. There are 3 main stages. First, you pay. Then, your insurance pays some, and you pay some. And finally, your insurance pays everything. So how does this work? In the first stage, at the beginning of the year, you pay for most of your health care until you reach your deductible. Remember that word? Deductible. A deductible is the amount of money you have to pay for your care before the insurance company will share the costs. So let's say your deductible is $500. That means almost every time you get health services, you will pay for all those services until you've paid a total of $500. It's like you're filling up a bucket. Once you add enough to that bucket so that you pay your whole deductible, then everything changes. Then you enter into the second stage. Now, every time you get health services, your insurance company will share the cost of those services. How much? That depends on your plan. Usually, you pay part of the cost, fees called co-pays or co-insurance, and your insurance pays the rest. But the second stage doesn't go on forever. If you reach a certain amount, you won't have to pay for any services. Remember that bucket? Every time you fill it with co-pays and co-insurance, your insurance company is keeping track. If you fill that bucket up to the top, everything changes again. You enter stage 3. From this point on, your insurance company pays everything for the rest of the year. That's right, every dollar of your health services paid by your insurance company. So what's at the top of that bucket? It's called your out-of-pocket maximum. This is the most money you will pay for your health care over an entire year. So let's say your out-of-pocket maximum is $2,000. After you pay your $500 deductible, and if you pay an additional $1,500 for various health services, you've hit your out-of-pocket maximum. From then on, you don't pay a penny more for covered healthcare services. It's important to know that every year, this starts over. So next year, you go back to stage 1 and need to meet your deductible yet again. So let's review. You pay a monthly premium to get into the club and get many preventive services free. You pay for other services until you meet your deductible. Then, you and your insurance company share the cost of health services. You pay co-pays or co-insurance, and your insurance pays the rest until you hit your out-of-pocket maximum. After that, your insurance company pays everything. So, how much does your insurance cost? You will at least pay for your monthly premiums, and at most, you will pay for your monthly premiums plus your out-of-pocket maximum. It all depends on the plan you choose and the care that you and your family need. You can get free help from a healthcare.gov assister to choose the plan that's right for your family.
Okay, I stopped sharing that one. Okay, let's go back to our slides. Okay, so that's just kind of a quick overview on how health insurance works. Of course, it's not quite that easy, and we'll get into that in a little bit. Okay, maybe we will, if my slide goes forward. Okay. So first of all, health insurance is, our healthcare in the United States is usually seen as an insurance market. And basically that's because we work with insurance. We don't have a government plan, right? And a lot of times people are facing uncertainty about the timing of health, like when you're gonna need your health insurance and how much money or how much health insurance you will need. As a result, some people pay insurance, and the levels of insurance depend on the amount of need individuals think they'll need during the year. So insurance contracts will then specify what each individual will or family will receive during that year. Insurance premiums specify what the people will pay. So that's the cost, right? So basically the idea is you pay a little bit now in order to avoid paying a big bill in the future. So this is usually easier to visualize with car insurance. So we're going to look at car insurance. So insurance companies are take a risk in exchange for the premium. Like they don't really know how much you're going to need. So if, say, when you buy your car insurance, that's pretty cut and dry. You get either full coverage, so if something happens to your car, you will get back the value of whatever your car is at that time because you've been paying those higher premiums all year. If you are just paying for the cost in case you hit someone, then you don't get the cost of repairing your car, right? You only they'll only pay for fixing the other person's car. So that's kind of, it's a little bit easier to visualize in that concept. But so the insurance company is taking the risk in exchange for the premium or the price that you're paying. And to be successful and to keep their doors open, they have to charge premiums that are cover everybody's healthcare costs that they are insuring. So basically, they're using these laws of chance and probability to predict what the cost is going to be for each individual that they are covering. So in your insurance premium, again, is the amount that they charge you. And premiums are set by, there's just a simple equation. So it's the cost divided by the number of people in whatever category. And the categories are usually defined in the United States by where you work, because most of the health insurance goes through employers, right? So, and I've used this example quite a bit, but I think it's a good one for this. So my family, we are under the university insurance, because the university, for the number of people, the category is basically healthy college students and professors that don't really take a lot of risks, right? So our costs are not that high in our category. However, my husband works for a construction company, and the majority of those workers are in the field using dangerous equipment, getting up on roofs. So they're in a more dangerous job. So their premiums are much higher. In fact, they're 3 times higher than what we pay through the university. So the insurance companies have gone through and done this profit loss and this probability of distribution of losses, and have decided that these people that work at the university, they're pretty good. They kind of, universities, like their students, although young, they're still really relatively healthy, and the older ones that they're covering are usually not that prone to accidents and that kind of thing, and usually pretty safe. Whereas on this other side, these are a bunch of crazy people who jump off roofs or whatever they do and work with machines that could kill them. So the probability is these people aren't going to cost as much. These people are going to cost a lot to insure, right? So now we start talking, this is where homework 5 really gets into. You guys are going to be working on how to do it on fair premiums, which is the amount of premium per person, or the average healthcare cost per person. And it's the total amount they bring in as premiums equals the total amount of healthcare costs, right? So we're just going to, again, put this in. I'm going to try to move this out of the way somehow. There we go. That's better. Suppose there were 10 people buying car insurance, and suppose that insurance company knew that it was going to cost $2,000 each. So in order to figure out the fair premium, you take the total cost, which would equal the 10 people times the 2,000, then that would be $20,000. So your fair premium is your average cost then divided by the 10 people. So that is the $2,000. So I'm going to show you, I'm going to stop sharing this, and because it's hard to work through the math this way. Usually I'd be on the board. So I am going to have someone do that for me.
All right, in this video, we're going to talk about actuarially fair insurance, right? So the thing to remember about actuarially fair insurance is that the premium that one would pay for actuarially fair insurance is the one where it is equal to the expected payout, right? So whatever one would expect to get paid out from insurance on average, whatever that number is, whatever that value is, if the premium is equal to that, then the insurance is actuarially fair. All right. And in that case, of course, the insurance company would not be earning a profit, right? If they have no other costs other than paying out to their insurance policyholders, then they would earn zero profits. But if they have any kind of administrative costs on top of that, then they'd be earning negative profits, right? Okay, so that's what actuarially fair insurance is where the premium is equal to the expected payout. Right? And as a simple example, let's suppose that let's think about some actuarially fair car insurance. And let's suppose that there are two types of accidents. The first is fender benders, and let's say that they cost $100 and they happen to 20% of drivers each year. And the second is collisions, which cost $2,000 and affect 10% of drivers each year, right? So a very simple example, right? We all know that there's many different types of car accidents that can have any amounts of damage, but we're just going to focus on two amounts of damage, right? And also we're going to act like we know the probabilities. Okay, so the expected payout for car insurance, right, from these accidents, right, fender benders and the collisions, well, it's going to be the 0.2, which comes from the 20% of drivers who have the fender benders, times the payout that would be necessary for a fender bender, which would be $100, plus the 0.1, which is from the 10% of the drivers that have collisions, times the cost of the collisions, which is $2,000, right? So this value here that we're calculating here, that's the expected payout, right? So it's basically like a weighted average, right? Where the weights are equal to the probabilities of the different payouts, right? So this first amount, the 0.2 times 100, that of course is 20. And then the 0.1 times the $2,000, that of course is 200. So adding these up, we see that the expected payout is $220, right? So in other words, what the insurance company expects to pay out on average across all of its insurance policyholders is $220, right? And if the insurance was actuarially fair, then the premium would equal that expected payout. And so the premium would be $220 as well. All right. Thank you for watching.
Okay, hang on just a second. Let me stop. Hold on. Okay, hang on just 1 second. I'm going to make sure this doesn't come back on. Okay. So that was kind of a little more in depth on what we were talking about. So I am going to try to dive into this a little more. Come on. Okay. So insurance companies don't know, right? They don't know how much it's going to cost for the year, but they can predict how much the cost will based on your characteristics. So your car insurance, what predicts how many losses you might have. So they can use, for car insurance, they use age and whether you smoke or not, where you live, the type of car you drive. Those are all things they use to predict what their losses will be for car insurance. And basically the principle is the same for health insurance. So if you have 10 people wanting, so for car insurance, I didn't realize I went on with this. So you have 10 people wanting insurance, 5 are going to have no accidents and 5 are going to have a healthcare issue, right? Or for healthcare, actually, you can do no accidents, and 5 are going to have some sort of issue, and their usage is going to be $4,000. So the fair premium would be based on the average healthcare cost usage, or the total cost. So 5 people times 0 cost plus the 5 people times the $4,000. So that would equal $20,000. So the fair premium is the average cost. So you take the $20,000 and divide it by all 10 of those people and get $2,000 each. and that is what they would charge for the premium. So you can't exactly know how much you will cost. So there's going to always be this randomization, but they can tell how much the average cost is for people that are like you. So they use your age, what you do, where you live. They can no longer use your history, your health history, or which is what they would use prior to this, but they can get a general idea of how much you will cost them. So it's the law of large numbers. So it's basically the central limit theory, and that means they take a sample, plot the mean, and take another sample, plot the mean, and basically take the average. So it's a normal distribution. And say they do this 1,000 times. So then the distribution becomes normalized, and the bigger the sample they have, the more certainty they have. So like these larger insurance companies are able to charge less, not just because they're spreading the cost across more people, but also because they have a better idea of how to predict what their cost layout will be. The result is if insurance companies get a lot of information about you and others like you, they can then predict with pretty good accuracy how much you are going to cost them. Okay, so we're going to get a little more complicated. So suppose you're working for a health insurance company, and this is exactly how you assignment 5 is. So you're working for a health insurance company. There's for 1,000 people you insure, the amount they visit the hospitals each year. So in group 1, and these are just maybe companies that they work for, there's 800 people. And so none of them go to the doctor or go to use the healthcare. Group 2 has 100 people, 1 of them goes. Group 3, 70 people, 2 people go to the doctor. Group 4, there's 30 people and five people use healthcare. So for the total number of visits, say each visit, each time they go to the doctor, it costs $1,000. So for group 1, that's 1,000, 2, 2,000, and 3, that's $5,000. So what the insurance company then does is they know that they could charge, if they knew which company was going to cost them, they would then charge those differently. But for this case, they don't know what each of these companies, what they actually do. So, so they would actually charge the fair premiums here as they were the cost per person. But because they don't know and they can't tell them apart, they have to charge everybody the same. And so they need to figure out that average across all of the groups. So they take all the costs that we just talked about and they add them up. So they get, so here's all the costs per the group. So you're taking this, and so the total cost for this group is $390,000, right? Because you're going to add it up for each person, and then you divide it by the number of people. So it's the total cost. So figuring the number of visits, and then divided by the number of people. So here we have 1,000 times 100. Yeah, that's right. Okay. 1, 2, 3. Yeah. So 2,000 times 70, 5,000 times 30. Is that right? I'm trying to add that up in my head. Anyway, so so it's 390,000 divided by 1,000 because you have 1,000 people. So the amount you pay for each visit before the insurance company pays. So the copayment, sorry, is the amount you pay for each visit before the insurance company pays. It can be a percent of the cost or a dollar amount of the cost. Example, the doctor costs $100 per visit. You visit the doctor 3 times. The total cost of your visit is $300. That's your out-of-pocket cost, right? Your copayment is, or that's the total amount of your cost. Your copayment, this is your out-of-pocket, sorry, got that backwards, is $20 for visit. So you pay $20 each visit or $60 overall. Your insurance company pays the rest of that 80% per visit, or a total of $240. If you visit the doctor 100 times, you'll basically pay 20% of your insurance, and the insurance company will pay 80%. And that's pretty typical. Deductibles are the amount of money you pay before the insurance company even starts paying. So this is often a large number or a large amount, $2,000-$3,000, and you pay everything until you reach that amount. So the doctor costs $100 per visit. You visit 3 times, you're paying $300. Your deductible is only $200, which I've never seen that or haven't in a long time. Your deductible is $200. So you pay the $100 for the first visit and $200 and $100 for the second visit, but then you pay $0 for the third visit. You can still have a copay on top of that. It just depends on your insurance. If you visited the doctor another 20 times, your insurance would pay the entire cost. Okay. So I thought this was a pretty good graphic here. So Gabriel pays copays or coinsurance, and the insurance pays the rest. So he pays until he reaches his deductible. And then he has to pay his copay, whatever that is, until he reaches his $2,500 out-of-pocket maximum. Once he reaches that, he's done paying anything. He doesn't have to pay his copay or anymore on his deductible. So everything after that is paid by the insurance. So copay is a fixed amount of paid a patient received in a particular healthcare service, and the remaining balance is recovered by the person's insurance company. The deductible, again, is a fixed amount the patient must pay during a given time period, usually a year, before the health insurance benefits cover the costs. So just a note, most deductible policies also have copays. So you pay the first $500, and then the insurance plan pays 80% after that. So if we were doing this with, so if you're figuring out a copay with a deductible, so you have your total costs here. So for your first $500, you pay $100, and then $400. And then you finally reach your $500. Say your next cost is $900. So you'll pay the $500 and then $80. So then you pay $500 and then the 20% after the next $400. So I'm trying to explain this. So now you've reached your deductible. So at this point, you only pay 20% after that. So on every 100, the insurance company now is paying $80. You're now paying 20 or $20. Then you reached your 5,000, so or 500 after. So you're going to pay 200 or and 20% off the next 1,000. So I know this gets confusing. So if you have group 1 So no one goes, no one, so no one's paying any insurance, right? And no one's going to the doctor. So in group 2, you have one person who goes, the cost of insurance to the insurance company is $900 because you paid your copay of 10%. So the cost for the whole group is $90,000. So for the 2 people who go, the cost to the insurance company is going to be $1,800 because, again, you're paying the 10% out of pocket. And this goes on to the $4,500, same thing. And then you're multiplying it by the number of people in the group. And then you divide, of course, by the total amount of people in under this company, this insurance company. So on the average, the fair premium for this insurance policy with the 10% copay is $351 per person. So without the copay, the fair premium is $390. With a 10% copay, it's $351. And then of course, if you figured it with the 20% copay, the fair premium would be $321. As the copay increases, obviously the premium then decreases. Also, as the deductible increases, the premium decreases. So the point is the insurance companies often have higher deductibles and higher copays because it lowers the premiums overall. Okay, so if you consider 2 policies, policy A has a $10,000 deductible, 20% deductible up to $100,000, no coverage after $100,000, and there are plans like this, but it's only costing $250 per month. Policy B, no deductible. It's only a 10% copay up to $10,000, no copay after $10,000. There's no limit, so it continues on. But the cost is then $1,000 per month. Option C is you just go without insurance. Which policy would you choose if you first were healthy and did not expect any major health problems, if you had a chronic condition, or if you had a history of breast cancer in your family, or you have a child with major health needs? So this is where it starts to get more complicated. So this is what you're going to be looking at for in assignment number 4. You're going to be looking at Covered California and trying to figure out which insurance plan to choose, right? So if you're expected to be healthy and did not expect any major health problems, you'd probably choose A or go without insurance, depending on how comfortable you were with either one of those. If you had a chronic condition, or if you had a history of breast cancer in your family, or your child has major health issues, you'd probably choose policy B. So it depends on whether the insurance company and the person have the same insurance, right? On who gets which insurance. So symmetric information, both have the set. So with symmetric information, both parties have the same information and the individual's health status, and thus they're likely to know what their health care usage will be. Policy A and policy B are offered at a fair premium. Whether or not it's to purchase it is how much money the purchaser has, or how much they are willing to take a risk. What happens when people start to select policies like A, B, or C? No insurance. This is what happens. So asymmetric information. So this problem arises when one person has more information than the insurance company. So we always have, and this leads to adverse selection. And we talked a little bit about this. So you know your health history, and so you actually have more information than your than the insurance company. So you're young and healthy. A fair premium is actually probably zero, because you don't really cost anything. If you have a chronic condition, maybe it's $1,000. A history of breast cancer could possibly be $2,000, depending on whether or not you can you end up with breast cancer, or if you have a child with high health needs, that could be upwards of $1,000. So now we're going to talk about adverse selection. So just kind of think about it in cars again. Suppose you want to buy a used car, but you cannot tell the difference between the good cars and the lemons. They all look great. They've all been detailed. There's nothing showing up on Carfax, but what will happen? So this is adverse selection within the car market, and it's caused by asymmetric information. The seller obviously has more information about the car than you do. So just to kind of, moral hazard and adverse selection can be confusing. So moral hazard, just remember, it occurs after the transaction occurs. And it has high incentive to engage in risky behavior, right? Adverse selection occurs before the transaction, and the buyer of the insurance is more likely to produce negative outcomes. So that's whoever the buyer is, they know, like, your health status better than the insurance company. So this occurs when the insurance companies cannot differentiate between high or low cost of individuals. This is adverse selection, remember. The result, only high cost individuals end up getting health insurance. And this arises from this asymmetric information. Consumers know their type, their high or the low, but the insurance companies do not. So this is why when the ACA first came in, there was a healthcare mandate that everyone had to get health insurance, because basically the young and healthy are paying for the old and sick, right? Because it's easier to spread the costs across a greater amount of people with different healthcare needs. And this is why when the mandate was basically taken away, or the penalty was dropped to zero, a lot of people's healthcare costs rose because insurance companies assumed, and rightly so, that only the sick or older people would be getting insurance. Okay, so pooling risk. So this is to explain this a little more. So you have group one, which are healthy, long-lived people. They'll cost maybe $1,000, right? And then group two are these sickly people who will die young. But if you pool them together, your costs are only going to be $1,500, right? But without some sort of mandate saying that everybody needs to get health insurance, what happens is only about 40%, I mean, these are just numbers. This is obviously could be different, but instead of it being 50-50, only 40% of the group one end up getting health insurance, and 60% of group two get health insurance, which then increases the premiums to $1,600. So you have young and healthy, 800 people who are young and healthy. They never go to the doctor. The premium is charged, it is $390, right? So the difference is they don't have to pay that $390. So that's money in their pocket. Then they have this group of 100 people. There's only one visit, so it's not too bad, but that visit costs $1,000. So but again, they're charging the $390. So now you're at $610, right? Because you take the $390 minus the 1,000. So it's costing now $610. History of breast cancer. Say you have 2 people in that, and that group, it costs $2,000 because they go to the doctor twice because they're getting their checkups or whatever. Even if they don't end up having breast cancer, they're still going to the doctor more often. So you charging that $320. So now you're shelling out $1,610, right? So then you have this other group that has a child with high health needs. Maybe, they live in the Central Valley, so they have asthma. So that's going to cost them $5,000. And of course, you're charging the same premium. So now you're up to $4,610 out of pocket for the insurance companies. So I'm bringing up the genetics and healthcare because it has been it's just people have been talking about, not so much since ACA came in, and most people think about it more often now. And also because I did, for extra credit, I did post up the eugenics, history of eugenics in the United States. And that's what kind of reminds me of what people are talking about now with genetics and insurance. And this is just a quote from Arnold Kemp. Indeed, the society of risk is an academic subject akin to the Black actuarial arts, which set insurance premiums. Even now, insurance companies are plotting to use genetic medicine to limit their own risk. So this is dilemma. If insurance do have, if you're as an insurer, because you can get your genetics tested for health, right? So if you have your genetic information and you have markers for, say, breast cancer or some other genetic disease, and you know that you are people at higher risk might pay more. The question is, how much more are you willing to pay? If your insurers do not have that same genetic information, people at higher risk might overinsure. So you have adverse selection. The question is right now is how much would that cost? So when I was pregnant with my boys, I had to get genetic testing. I don't know that they make you do that as much anymore. Anyway, to see what my risk, what the possible risk was for them. And my genetics are, I don't really have a lot of predispositions, but so it wasn't a big deal. But there are other different diseases that could pop up in certain genetic populations. And so that's what they test for. And so if that did pop up, I mean, of course, for this, if my child had one of these diseases, what would we do? That's kind of what that's for. But I do have had friends who have decided to get mastectomies because they do have the marker for breast cancer. And so, that's going to cost the insurance company a little bit more, right? And at that time, maybe not in long term, but it could possibly. So moral hazard. So now individuals have no incentive to take actions to reduce claims, no incentive to take preventative actions, no incentive to search for more efficient producers. Providers have no incentive to take actions to reduce charges. So they can charge insurance patients different fees than private patients. And this did start happening. Remember, we talked about it in the 70s and really in the 70s, but also somewhat in the 80s. Hospitals and doctors were using insurance patients to offset the costs of the uninsured, and that's a moral hazard. But also, they find in a problem that they have seen more so in New Zealand is interesting because they have government, they have like a Medicare for all or government-based health insurance, but they also have government-based accident insurance. And so what they found was, I think it was the 90s, where when this first came in, people were starting to take more risks. So you see, like in New Zealand, that's where they started bungee jumping, and that they had this thing, like these crazy jobs or crazy things. People would jump out of airplanes and try to roll cows and just crazy stuff. I don't care how much insurance I have. I don't think I would jump out of an airplane and try to grab a cow. I don't think that's something I would ever do. I have bungee jump, so obviously that's something I would do. But yeah, so they just so you find there that they don't have as many. There's not as like here you have signs, careful wet floor, careful this, careful that, and there you're like on your own. Like if you can't figure it out, you will get hurt. I mean, obviously that's an extreme. They do put out signs and stuff, but they did find an increase in accidents and costs to their ACA, which is their accident insurance. I think that's all leveled out now. It was just when it first came in, and basically young men, I think, they're covered. So, but that pool has a lot of money in it now. So I don't think it's so much of an issue. So without copay, your fair premium is $390. With 10% copay, this is just to remind you, with a 10% copay, your fair premium is $351. With 20% copay, $321. And basically the point is the insurance companies are offering higher deductibles, high copays and policy because it lowers the cost of premiums. Remember that, right? So this also reduces moral hazard. If you have skin in the game, basically, if you are if every time you go, you have to pay, that reduces your chance of taking risks. Otherwise, and so basically you get an experience rating. So premiums are calculated on the basis of an individual's own experience over time. So often insurance will have these things, especially in car insurance. You don't really see this in health insurance, but no claims bonuses. This is why you get non-smokers discounts in car insurance, or good student discounts, or loyalty discounts. All of these are ways to reduce that moral hazard. So supplier induced demand. So this is a problem with your agency, principal and agency relationship. So your physician has superior knowledge, right? And the patient is dependent on the physician. So this agency relationship exists when one party must rely upon the other party to make good decisions on their behalf. So in healthcare, this is the physician is the agent for the patient, right? And this agency relationship is formed when the principal delegates decisions to that agent. So you are the principal. You have delegated the responsibility of your health to your physician, who has superior knowledge in the way your body works, in overall health and your being, right? So the principal recognizes that he or she does not have all of the information. So the perfect agent makes decisions that are best for the patient or the principal. Potential problem. So how do you ensure that the agent acts in the best interest of the principal? So example of buying a car. You can ensure that you are buying, how can you ensure that you are buying a quality car? So you can look at the seller's reputation, look at contracts for services, and this is, you can talk to other people who have had this type of car before. So this is really that principal agent problem. So this is imperfect information in health. The question is, why don't patients contract for services? How can a patient identify the appropriate amount of inputs? So it's really hard when you are a patient to know how much care you should be getting, right? And how do you contract for good care? Like, what is good care? So there's really this danger of supplier-induced demand and poor quality of healthcare. So again, when we were talking about the 70s in our previous lecture, this was really kind of a huge issue at this point. Doctors were, and still to some extent today, well, actually, to a large extent today, especially in the United States, they're very afraid of getting sued. So they order lots and lots of tests, right? In order to ensure that patients are getting their good health care, or that they're just not going to be sued. And there comes a point when maybe that's too much, and that actually has gone over the top. So the claim is that healthcare providers can do and use superior knowledge to influence demand for their services. As more doctors come into the area, doctors tend to raise their demand by treating more people, right? This suggests that they increase demand when it's faced with increased competition, but they do not decrease the price. So like in cities, you often, because there's more doctors, what they will do is, what they've seen in studies is that they, in certain areas, they request more tests, more higher end diagnostics than they do in, say, a rural community where there's one doctor and there's no competition. Why would this be, and does this indicate a problem? So again, we have this problem with this asymmetric information that results in this principal agent problem. So it's difficult to identify the quality of care, right? So maybe everybody should be always ordering this number of tests, right? Maybe the rural doctor isn't doing his job because he's overburdened with the number of patients. I don't know. It's difficult to identify whether care is needed or not. The result is incentives exist for professionals to abuse this problem, right? Because they're getting paid. So they get paid every time they order the test, right? So ways to ensure this problem does not exist. So some sort of accreditation, more training, medical codes of ethics, and of course, government regulation. So as an example, so this happened actually to my husband's aunt. She lived up in Reading. This was about 10, well, maybe probably 20 years ago. There was a doctor who was basically scamming Medicare and giving a lot of people unnecessary heart surgeries. He has since been lost his license, but what ended up happening is, like, Medicare is actually government regulated. So he was not maybe the brightest using Medicare. It's much easier to hide these things in the insurance market. Anyway, so Medicare and Medi-Cal constantly are checking. And if they see this huge spike in this one area and with this one doctor performing all of these surgeries, whereas in because they can look across the whole United States, remember? So they go, wow, this Reading, like every senior seems to need heart surgery. That's not going on in the rest of California or even the rest of the United States. So they're able to track that. And that's the government regulation that actually works pretty well. So ACA, to kind of bring it back around, is really about health insurance. Understand, you need to understand how health insurance premiums are set. You need to understand the difference between deductibles and co-payments. Adverse selection is, you understand why it is so difficult to have no pre-existing condition criteria. So, because, and remember that adverse selection, you know more than the insurance company, right? So if we have no pre-existing conditions, it's harder for insurance companies to decide on what the fair premium is going to be. Moral hazard, understand the problem that the insurance companies face and why they use deductibles, and then understand the principal agent relationship and the problems that patient and insurance companies face trying to insure their health care. So, conclusion of the concepts. So if anyone has any questions from this lecture, of course, you can always email, text, or call or ask during our next meeting, which is going to be this Monday because I had to cancel Wednesday's meeting. And then, of course, we will go over it the Wednesday, each assignment before it is due the following Monday. So this next on Monday, we will go over assignment number 3, right? I think that's what we're on. So enjoy the rest of your day, and hopefully I'll be uploading again shortly. And stop recording.